Good afternoon, everyone. How are you going? David Johnson's my name. I thought I'd just start my talk by taking the opportunity to thank my Brisbane team, Rehab, Kate and Skylar. You guys make my work really easy and always go above and beyond the expectations. So it's a real team effort, and it's an absolute pleasure working with Mainstay. We're going to talk a little bit about rehabilitation, and I sense that in the last hour or two, hour and a half, the discussions have become more complex and a little bit more conjectural and indicative of maybe some of the stumbling blocks and hurdles for clinicians moving forward with confidence in this system. But I'll try to talk to you about my sort of 15 years experience in back pain rehabilitation. That just seems to be in 10 minutes if I can. I'll point here. So just a bit of a disclosure. No stakeholder in Mainstay. As yet, no shares in the company, but I'm eagerly waiting Jason to let me know when the IPO goes out. But I also run a surgical practice. I've done quite a few reactivates now, enough to be fairly confident in the utilisation of the device, and I'm very happy with the outcomes. The other fantastic thing about Reactivate is it's a non-destructive procedure. It has a very safe risk profile. It's a day surgery procedure for me. And I also am very much involved in rehabilitation of back pain. A sidearm of my practice is rehabilitating physical therapists, teaching physical therapists how to rehabilitate back pain. And so hence my involvement. Well, I suppose it is rehabilitating them in a way.
I was going to say your LinkedIn would suggest otherwise.
Now, I was involved in the international guidelines for ReActivate, which I thought was a wonderful project to be a part of, and a really necessary project. But as we've sort of spoken about in the last hour, we still need to go much further with developing a deeper understanding, both from clinicians' standpoint and also the physical therapists, so that we are maintaining that consistency, as I said before. Like when you go through a McDonald's drive-through, you kind of know what you're going to get when you order that cheeseburger. And this is an open access article. You can download the whole article there, Michelle. Have a good read. There's lots of stuff. But today, I think I want to really focus more on the bold print stuff that I feel is very important, and that's the biomechanics of the lumbar-pelvic spine, and that's what we're trying to fix up. We're trying to fix up instability, functional instability of the lumbar segments, which are joints, and so therefore biomechanics plays a very key role in the health of all joints. So when we talk about rehabilitation, for the surgeons, we've all done fusions, discectomies. Some of us have done scoliosis surgery. Some of us have done spinal cord neurostim. Rehabilitation is kind of part of that process, right? So is there anyone who does a spinal fusion or a discectomy and really has no post-op or peri-op rehab plan? Like, would you just do the discectomy and say, see you later? Or would you have would all of us sort of agree that we have a post-op peri-op plan after any spine surgery? So it kind of makes sense that when we implant a ReActivate device, we have to have a rehabilitation algorithm as well. And that begs the question, why do we do rehabilitation? What is the purpose? Like, are we just keeping patients busy while they're while they're using up their sick leave? Well, no. The primary purpose of rehabilitation, I see it, is to rehabilitate and address why the patient needed the surgery in the first place. Like, why did someone need a microdiscectomy? Why did they need a laminectomy? Why did they need a spinal cord neurostimulator? And of course, why will they need a ReActivate? There are some secondary benefits, of course, when you had a pain condition, you're obviously going to reduce lifestyle activities, you're going to reduce your functional capacity, and the rehabilitation should also try to address that and restore their ability to go back to their pre-surgery status and return to the quality of life that they are satisfied with. There may be some symptom-based improvement with the rehabilitation as well, but that's normally managed effectively and simply with pharmaceuticals in the post-op period. So what could be contributing to poor outcomes from surgery, especially when it comes to back pain surgery? And even though Reactivate is not, in my books, considered a spinal surgery itself, it's a functional surgery, whereas spinal surgery is a structural intervention. This is a functional intervention. What could possibly be causing poor outcomes from back pain surgery? And I'm sure we've all heard of failed back pain surgery. And what are the possible contributors to that? Is it that as surgeons we're just technically not very good at doing PLIFs, T-lifts, A-lifts, disc replacements? Is it that we're not very good at choosing our patients? Is it suboptimal pain control perioperatively? Or are we going to blame the patients? Have they got abnormal illness behaviours and malingers and just don't want to get better? Well, I think for the most part, those things that I've listed there are not a huge contributor to poor outcomes after back pain surgery. Yet the literature would invariably quote a failure or success rate of around 50%, which is incredibly poor. And that's really not acceptable when we're talking about surgery that you can die from and bleed to death from or sustain severe neurological injury from. Little less than the costs to the patient and society. But could it be that the rehabilitation around the surgery is where the problems lie? And if you type into Google failed back pain rehabilitation, you effectively get nothing. There is no return on a Google search that talks about failed back pain rehabilitation. It'll just bring up failed back surgery. So globally, there's this very poor understanding of good and bad rehabilitation for back pain. There's a little bit, possibly and most likely published by myself and a few other people, but really for the most part, the global literature does not even recognise what I've coined as failed back pain rehabilitation syndrome. And I think that's a problem because of course there can be good and bad rehabilitation. And of course we want to steer away and guide our patients towards good rehabilitation. So with that premise, we've got to ask ourselves, what is the objective of this surgery? Because the rehabilitation should be to focus on why the patient needed that surgery in the first place. And we all have agreed, we've talked about it a lot today, that it's to restore multifidus function. And the video there shows very clearly a normal multifidus and an abnormal multifidus. So why has this occurred in this patient? What is the cause of these functional and structural changes? The rehab has to address that. And this was a revelation for me. Thank you, Jason and team. This was an absolute revelation to see that we have a recognised ICD code, a recognised diagnosis of multifidus muscle dysfunction. Because now in terms of insurance and legal cases, we can actually list this item code as the diagnosis of what we are treating. It's very, very important. But at the same time, you can still take it one step back. And I kind of think 61.84 will be this movement dysfunction concept, okay? Because as the fellow, sorry, don't get, Josh, made the analogy with the ACL and the quadriceps wasting, something still has to cause the multifidus muscle dysfunction. And it just makes sense that movement dysfunction will drive the evolution of multifidus muscle dysfunction. So we still need to treat the movement dysfunction as part of our rehabilitation. And when we do that, we kind of develop a very measurable, repeatable, testable, cause-based clinical model for back pain. The disease of movement dysfunction drives the multifidus dysfunction and atrophy. We then develop functional instability. Functional instability causes our nociception and inflammation, which is what makes our patients come to us. And then if that's left unchecked over time, we will develop the accelerated structural changes, which should not be referred to as degeneration. Degeneration is a normal process of aging. It's accelerated degeneration, and so maybe we can use the word degeneritis to denote pathology as opposed to normal degeneration, because we often get mixed up in that nomenclature as well. We're saying you'll see a lot of the times insurance reports that the patient has normal age-related degeneration, and yet they're in pain. No, that is not degeneration, that is degeneritis. And it's pathologically and physiologically different to degeneration, which we probably all have, and our elderly parents probably have. It doesn't mean that they have pain though. So this is important to be measurable, repeatable and testable in scientific rigour. That's an important element of scientific rigour. And movement dysfunction I've sort of defined as an acquired ubiquitous functional disease of modern industrialised lifestyle, manifesting with musculoskeletal pain, disability and then structural compromise. And it's really just simply following central tenets of medicine. We always treat the cause in conjunction with the symptoms, and that's essentially what the mainstay and the ReActivate paradigm is. We're addressing causation, we're addressing in conjunction with addressing symptoms of back pain. Of course, we're going to treat symptoms at the same time as addressing causation. And the evidence in global literature that supports that we are currently not doing that. Number one is that back pain is an epidemic, and some of the leading researchers on the planet have very, very confidently told the industry that there is no cause for back pain, and that's fundamentally has to be wrong. By definition, you cannot have an epidemic of pain without a cause. They go hand in hand. Now, we all have a fairly good understanding of stability, right? We can go back to the early 90s when Punjabi published his papers on motion segment stability, very clearly described 3 subsystems, the active contractile elements, the passive non-contractile elements, and the neural control elements. We've got a very good understanding of this, but most of us don't have a good understanding of neural control elements of the lumbar motion segments, and that's where the rehabilitation needs to focus on the neural control. The active and passive elements associated with lumbar motion segments more relate to capacity of the spine, whereas the neural control elements relate to the health of the spinal motion segment. I would actually rather a patient be a fairly weak person with a relatively weak core with very good neural control. That patient will not have back pain. They may not be able to do very much versus someone who, and I see a lot of athletes, I see a lot of professional athletes. They're the fittest people on the planet, and they have extremely high levels of active and passive subsystems controlling their motion segments, but they have very poor neural control. And even though they've got a six-pack and ripped TAs, and you can see every muscle fibre, they have terrible back pain. And that's because their neural control is very poor. And when we focus on that as our rehabilitation target, they then have both. They have great neural control and they have great active and passive elements, and that's what returns them to success on the sporting field. But most people who come to see you are not asking to get a six-pack. They just want you to get rid of their back pain, and they leave a physical therapy service 6 months later with a six-pack and they still got their back pain. That's not what they came for. And further evidence to support this is that how often have you read a colleague or a medical report or an insurance claim report in legal documents within the patient's file in a patient with back pain that actually talked about the patient's movement quality? In 20 years of working in this industry, I've not read one report from any element of the back pain therapeutic industry that has described movement quality of the patient. We're just not thinking about it. So our rehabilitation has to define functional movement, and it has to define proficiency of functional movement. It's like the rules of the game for moving, and we're all part of that game. We're involved in what I refer to as the sport of life. And just like any sport, if you're playing golf, if you're playing lawn bowls, if you're playing tennis, you need rules of how to play. And these are really the very simple rules in regards to the lumbar pelvic spine. These are the very simple rules that dictate how to express your movement in daily life activities to be functionally proficient. And it's not hard. The little toddler already knows those rules. It's kind of hard baked into your DNA. These rules are baked into your DNA when you're born and as you progress and as you evolve. And it's no different for the toddler picking up his toy truck as it is for Dmitry Klokov breaking a world record in an Olympic snatch. The biomechanical movement principles are identical. It's just that when we live in a modern society and we start going to preschool and we then go to primary school and then we get a university entrance and we sit at our desk and then we start working in an office 8 hours a day and then we become, we just choose to live in this modern society, we start to corrupt. We start to corrupt this movement. And if you just walk around the shopping centres, just walking around your neighbourhood and watch people moving, they're moving horrendously. And it's a very simple paradigm that movement dysfunction then drives the progression of the domino effect right down to the accelerated structural changes that we then get referred. So this is an example of patients engaging in what I call functional movement therapy. And I don't tell the patients that they're doing physiotherapy or core strengthening or exercise. I don't use those terms for very good reason, because 99% of my patients who are coming to me as a tertiary care specialist have already done that for 5 to 10 years. They don't want to do that again. And I'll say to them that the rehabilitation that they've done has not been specific enough and distinctive enough to restore their multifidus muscle function, and therefore they have functional instability. And if we correct that, they'll be able to improve their stability and reverse engineer the problem. And I use the term virtuosity because virtuosity means being exceptionally good at the unexceptional. And when I restore someone's functional movement proficiency, their rehabilitation is actually 24/7. It's not a 30-minute session with the EP or physio or osteopath 2 times a week. When I've restored their movement proficiency, they are rehabilitating from when they put their feet on the floor in the morning and get out of bed, to brushing their teeth, to then going down to the kitchen, opening the dishwasher, getting out a coffee cup, opening a drawer. Every single movement that they're doing in their day is part of their rehabilitation. And that is what drives the synergy between the central nervous system and this implant. They have the same goals. And that's why I think the patients that I have implanted really get a very rapid improvement, probably within 3 months. I know that the studies talk about 3, 6, 12 months. I'm seeing significant improvements within 3 months. And I would get worried about a patient not improving at the 6-month mark if they said they're not getting better. Because we're creating this powerful synergy between the device and the central nervous system. So that's our modern he, him man doing the vacuuming, movement dysfunction. So this fellow is now driving multifidus muscle dysfunction. He may not yet have back pain. He doesn't look like he's got back pain yet, but he's on the journey to developing functional instability. It's a little bit like smoking cigarettes. You've been smoking cigarettes for 10 years. You don't have emphysema yet. You don't even feel short of breath yet, but you're on your way to developing it. Or he could, as we said, fall down the stairs on a wet floor and develop immediate back pain and then develop immediate movement, multifidus dysfunction. It's the same thing. One just happens very slowly, the other happens suddenly. We call that an accident. But the same principles apply whether it's happening in micro insults or in one large insult. But that, in my mind and my framework of understanding, gives me the confidence to talk to patients and get them over that understanding into an understanding of functional deficits versus the very easy to understand structural deficits. It's bizarre that some patients would much more easily understand a ALIF versus this operation. And the consenting process and the counselling and education process is difficult if you don't have that conceptual understanding of functional deficits and functional rehabilitation and what we're up about. And I'll just leave you with my own MRI scan. I used to have a lot of back pain every day. I'm still working. 2013, I thought I'd better get an MRI scan just to have a look, see if I've got a tumour or something. And I had multifidus atrophy. This was around the time that I started really getting interested in functional training, probably because I thought I had to strengthen my core, but it very quickly transitioned into not core strengthening, but improving on my biomechanics, and Olympic weightlifting was one of the little journeys that I serendipitously went on. And taking on Olympic weightlifting as a sport made me focus very much on biomechanics, because I learned in the training that the strongest person in the room often didn't lift the heaviest snatch or clean and jerk. It was the person who moved biomechanically the best. And after several years of doing a lot of functional training, my back pain obviously disappeared. I still have the anterolisthesis. I still have the facet arthropathy. My multifidus, I believe, is a little bit more dense, but I am 100% certain that my multifidus function is better. So I'm not really worried about the loss of that, the sort of flakiness of it still, but I know my multifidus function is better, my proprioception is better, and all of my other stabilizers, my general stabilizers and my mobilizers, can now do the work and allow me to have a very high functional capacity. Thanks a lot.